thank you for the invitation. This, as has just been mentioned, this study has had a massive impact in the management of major trauma patients in the UK, and definitely has played a big part in the survival of hundreds of patients. But before I go on, it's probably worth thinking about what we mean by trauma, because a lot of people talk about trauma, and Google certainly suggests that when you talk about trauma, people think about psychological distress, PTSD, but what we're talking about in this report and what I talk about in my work is physical trauma, usually as a result of blunt force to the body, which causes a great deal of severe injury. So these kinds of mechanisms of injury will be the cause of trauma. So road traffic collisions, whether it be a cyclist, pedestrian, driver, increasingly in urban centres we're seeing a lot of assaults, penetrating injury with knives and lesser so guns. And more recently, obviously, the well-documented mass casualty events where there's bomb blasts or marauding shooters and stabbers. So all of this is trauma, or the causes of trauma, causes of traumatic injury. But this is what trauma patients look like. Now, obviously, this is just one patient. This is Elaine, a patient who was injured before we had the change in the way we manage our patients. So months after the original NCPOD report, Elaine left home in the morning, as we all did this morning, got on her bicycle here in London to cycle to work, was hit by an HGV, sustained very severe injury, and sadly died a number of hours after that injury. And so when we think about trauma, we're not thinking about somebody who's fallen over and perhaps broken some bones in their hand or even broken their hip. We're talking about somebody who has severe, life-threatening injury, often as a consequence of large brain injury, bleeding, dysregulated clotting, widespread inflammation, etc. And sadly, Elaine was such a case, and her family very much wanted to highlight her care, so that as we moved forward with research and with changes in practice, people became aware of the need for change. But we didn't really understand the fact that severe injury was such a big deal, and actually trauma is quite small in comparison to cancer and cardiac disease, but it is the leading cause of death and ongoing disability for patients in the first 4 decades of life. And it's actually becoming an increasing burden in older people as people are living longer, staying active for longer, and falling or out and about, as you saw on a previous slide with somebody jogging across one of the bridges. So it's a big deal for all ages, but certainly for our younger people, you know, us, our children, our grandchildren. But we haven't really always understood that, and going right back to 30 years ago, this report by the Royal College of Surgeons looked at 1,000 deaths as a result of trauma, and this report found that probably 2/3 of these deaths were preventable. And one of the main findings was that there were severe, serious deficiencies in the management of major trauma right back then in 1988. And nothing happened. There were a few interested people, there was a sort of a few coalitions of the willing and the interested, but really nothing happened until 2007, when the NCPOD report was published called Trauma, Who Cares? And this detailed a study that looked at the care of severely injured patients over a 3-month period, February to April, and a busy winter period where we see a lot of trauma, and they looked at the care of the patients from the point of injury through to the first 72 hours. So that those very critical hours where we need to be able to recognise the injury, get the patient to the right place, and start the treatment by experts as quickly as possible. And as with standard NCPOD processes, they had a group of peers and experts who reviewed the cases, used the evidence, albeit limited evidence available, to try and judge the quality and the outputs of the cases across the country. So it was England, Wales and the north of Ireland. And they looked at the care of 795 patients in that 300 period, and they found that almost 2/3 of patients had less than good care. So 2/3 of patients had deficits or deficiencies in the way they were managed. And we've heard about how surgical jam is spread very thin. Well, trauma care was spread paper thin. So we had hospitals, small A&E departments, and perhaps seeing 1 trauma patient a month, 2 trauma patients a month, and having to deal with patients like Elaine. didn't have the resources, didn't have the capability. We had other hospitals that were doing better because they were seeing 20, 30 patients a week and they had the resources in place. But at that time, anybody went anywhere depending on where you were injured and where the local A&E department was. Deficits were unsurprisingly around being able to recognise severe injury. Patients don't always look like they're lying there and they've got a knife sticking out of them. They just look really, really sick. And there are multiple systems injured. So there were delays in recognising injury early on, delays in expert intervention, and lots of delays in senior review. Consultants sometimes weren't involved in the care for many, many hours and if not days later. Mortality in that first 72 hours was 15%, so that's 170 patients died in those 3 months. Imagine if there was a disease that was killing 170 young people in 3 months. Imagine what the Daily Mail and the Daily Express would make of that. But of course people think, oh well, you know, there's A&E departments, there's ambulances, we can put a drip up on them, they'll be okay. But actually it's much, much more complex than that. And one of the main highlights that was raised at the end of the report was around the fact that the deficiencies again were organisational, as has already been said this morning. It wasn't that people didn't care, it wasn't that people weren't interested, it's just the organisations weren't in place to allow the expert management of these patients. And this was listened to. This report was highly, highly important. And for those of us that read the report and had been aware of this, we were thinking, yes, finally. And in the NHS at 60 review by Healthcare for England, the Department of Health, and Lord Darcy, looking at the international evidence and then the evidence from the Trauma Who Cares NCPOD report, said that it was now compelling. We need to support this organised, regionalised system of care that we had for cardiac patients and for some cancer patients, and we needed the same for those with severe injury. So in April 2010 we got it. And I've sort of glossed over a huge amount of work there, let me just say. A huge amount of work. Healthcare for London at the time, as was said, the Tsar was appointed, and there was a huge amount of work around designation and who would be best to take these patients and where they should go. But the London Major Trauma System was launched in April 2010. You can see that it's a geographical system. It covers right out to Southend in Essex, right down to Canterbury in Kent, out to Surrey and up to Watford. So London is divided into 4 networks, and each of the networks has a major trauma centre, the box, who are responsible for the management and care of the most severely injured patients. And then the smaller hospitals are not just any A&E department, they are designated trauma units that can manage the less severely injured patients, but also have the capability and the pathways in place to treat and transfer as quickly as is needed back up to the major trauma centre. So that was absolutely amazing. We got pathways in place with the London Ambulance Service, the London Air Ambulance Service, and we were able to really regionalise our trauma care in a way we'd wanted to do for a long time. And did it make a difference? Well, in 2013, we went back to NCPOD, thank you, Neil and Marisa, and we asked them if we could rerun the study looking at our major trauma system 3 years after implementation. So far from being mature, but maturing. So we used the same NCPOD methodology, same 3-month period of the year, obviously a different year, same inclusion criteria, expert review, etc. We included some experts from the original study and brought them back down to London and used some of our local experts and peers to review what had been going on. And from a process point of view, things had really improved. As we would expect, we'd gone from no organisation to an organised regional system. So access to specialists, to trauma teams went from 16% in the original study up to 84%, and then involvement with senior clinicians very early, within half an hour, often within 5 minutes, a consultant there directing the care went right up to 92%. And there were lots and lots of process of care improvements across the board. When we looked at the NCPOD quality criteria, again, we'd gone from 43% good care in the NCPOD study up to nearly 70% in our study. And there were reductions in deficits across the organisational and less than satisfactory categories. But where we were surprised were the very small reductions in clinical deficits. We thought, well, hang on a minute, why? You know, we've got this system, we've been going for 3 years, why have we still not seen a huge reduction in clinical deficits? So we went back to the data, which was amazing because we had, the NCPOD data set that we could look at. We had our data set, and we looked to see that actually it was the elderly patients that were really skewing our data. And over the years since the original study, the numbers of elderly patients had really increased. And they were still being taken to the smaller hospitals because they didn't have really obvious severe injury first, but then they were found to have, significant brain injury, significant orthopedic or orthoplastic injuries. And we hadn't really thought about properly supporting the smaller hospitals in being able to manage these patients. And you could see that actually only about 23% of the severely injured in the major trauma centres are elderly, whereas it's nearly 60% in the trauma units, because they don't fit the sort of normal triage criteria, or they didn't then. So as a system, we had to come up with a set of guidance that we could roll out across the system to help better support the clinicians working in these smaller hospitals faced with large numbers of severely injured patients. And being able to use that original NCPOD methodology really helped us dig down on the data and look to see exactly where the clinical deficits were occurring. Despite those deficits, mortality had really improved. The overall mortality, you can see, had gone from 15% in NCPOD down to 7% in London. So that was really, really encouraging. This is really unadjusted mortality. And then across the x-axis there, you can see injury severity score. Severe starts at 16, and highly critically severe is 36 and above. So you can see the biggest survival benefit was seen in the most severely injured patients, which again we were expecting, but it was great to see the data to confirm that. And that has been confirmed nationally, because 2 years after we rolled out our London Major Trauma System, the National Trauma System went live. So there is a similar model now throughout England and recently Scotland and Wales. And this paper was published by Professor Moran, who is now the National Clinical Lead for Trauma in the UK, in England rather, and he published this study looking at pre-system and post-system data across the whole of England. And as part of the NHS 70 celebration, this was the headline, that more than 1,600 patients have survived as a result of regionalised trauma care in England. And that is massive. That's a huge amount of young lives saved, a huge amount of the future secured, and it goes on. And this really could not have happened, we believe, without the support of NCPOD and that original pivotal study. So on behalf of my colleagues, we'd just like to say thank you.